Good afternoon, colleague. Evening, actually, colleagues. As I said that we're going to be discussing some pediatric surgical emergencies, which are many, if I had to count. But I had to sit down and say, what are the common emergencies that I think that you might inquire in your practice as you practice from different levels of care, and as different practitioners expected to provide different care of insight. So I came up with 7 topics, which I think they are very critical, that we will quickly go through since we have also lost some time. So I will discuss hypertrophic pyloric stenosis, since I want to start up, going down. And then we'll discuss a little bit of malrotation and mid-qut volvulus. From there, we'll talk about intussusception, Hirschspung's disease, a little about anorectal malformation, as it's a very vast topic to actually discuss, but I will just speak about the considerations that you as a practitioner need to look at and how to manage the patient from your setting. And I will spend a little bit of time on inguinal hernias and abdominal wall defects. So since I've been allowed to, I will continue on my own screen this side. So at the end of this discussion, the important or critical points that I want us to be looking at when you live here on these 7 topics is you need to have an appreciation of what is wrong with your patient. What do you think is a differential diagnosis based on the clinical picture that the patient before you actually shows? And because of you have now an understanding of what can be wrong, then how do I investigate this patient so that I can confirm at least what is wrong with them? Because the topics I chose actually can be diagnosed at base hospital. And then once you have diagnosed this, then is what can you do from that primary hospital for interim management of this patient so that we have an alive patient by the time we have to transfer the patient. Then one of the things I wish I had time to speak to is patient transport considerations, because that is where the glitches are. You can make a great diagnosis that we all expect a patient, but our patient does not get to where you want your patient to get. So I would like to spend a little bit of time on that. And then the other thing which I will give a hint on as we go through the topic is what then happens? What is the definitive management of this patient before you? Where should this patient be treated? When should this patient get there, and how? Because those are the 3 considerations that one has to look at when you have you are deciding how your patient is going to be managed. So like I said, the first topic that I will talk about is hypertrophic pyloric stenosis. As we understand that I always say that every condition in medicine, when you ask what is hypertrophic pyloric stenosis, everything in medicine, the answer is in the question itself. So we already can realize that it's hypertrophy of the pylorus, which ends up causing a stenosis. And we need to know how do these patients present, because most neonates, actually, especially the preterm ones, it's about 60% of them have some form of vomiting after being born for the first month. And this vomiting needs to be looked at in perspective, because most of them have gastroesophageal reflux. And most of those patients who present with gastroesophageal reflux in the neonatal period will actually overgrow their reflux. They do not need surgery. It's very, very few patients who has maybe a hiatus hernia that needs that. So what kind of vomiting does this patient have to have for us to say maybe we should be looking at HPS? We talk about non-bilious vomiting, and we understand why it's non-bilious. It's because the pylorus, which is a pre-duodenal structure, is where the obstruction is. And these patients have projectile vomiting because they feed and feed and feed because they are so hungry, and their stomach gets so full of food that when emesis starts, it's such a forceful vomit that they vomit quite extensively, and it's mostly milk. And one of the key things you need to look at when you look at patients with HPS is failure to thrive. They actually look very hungry. You look at this child, They are sucking on something. They're either sucking on their tongue, they are sucking on their clothes, they are sucking on the mother, because they are chronically hungry. Because they do get the nutrition, but the nutrition, because of the vomiting, actually goes out. So they look a little bit hungry, as if these patients are from an area where there's famine. So we need to know, how do we investigate? Now we've got a child with projectile vomiting in front of us. They look very, very hungry. How do we investigate? What can we get as a diagnosis? You can do arterial blood gas on these patients. So if you vomit, we know that you vomit your hydrochloric acid. So if you're going to lose your chloride and you're going to lose your hydrogen ions from your stomach. Because you're losing that chloride, that is where the blood gas, you're going to have to get hypochloremia. That is where the hypochloremia comes from. And also, you look at, if you lose your hydrogen ions, you're going to end up being alkalotic. So that's part of where your metabolic alkalosis is going to come from. And we know that these patients are dehydrated. So as part of the body dealing with dehydration, you're going to get your renin, angiotensin, aldosterone system setting in, where your sodium has to be preserved at the expense of your potassium. And that is why then your blood gas, which is your diagnosis, a feature at base hospital, your blood gas will show hypochloremic, hypokalemic, metabolic alkalosis. And if you have a patient like that, then you think, I think this patient has a pyloric stenosis. And because of that, then you think, what is now the modality that will confirm pyloric stenosis? We use an abdominal ultrasound, which is when you will, on abdominal ultrasound, they will then measure the channel and the actual thickness of the pylorus. So we need to understand that some of the things that then you need to look at is that about 10% of the patients with hypertrophic pyloric stenosis have a certain level of positive family history. So ask the questions. Has any child before in your family had pyloric stenosis? These patients usually present between day 7 of life to up to 10 months. 3% of them are premature, and we are looking at the weight of about 3 kilograms. But please look out for a male child. Most of them are male children. So if you have those, the history, you have the clinical symptoms, and it's a male child, most likely you're right. So now you think, my patient has pyloric stenosis. If you are in a center where you can do ultrasound, you can do ultrasound. If you don't, then you can present the patient to us. But it's important to keep a patient NPO, because they are going to continue vomiting and their state of dehydration worsening. There's controversy on whether they need a nasogastric tube or not, as I've explained to you. If they're not vomiting and now you put nasogastric tube, you are making them to continue their metabolic vicious cycle. So you're actually getting your patient worse than they are. So I always say, if your patient is not vomiting, keep him NPO and do not put nasogastric tube unless you are worried about your patient is vomiting. So then we need to correct the dehydration immediately. That's why you need to resuscitate these patients with fluids. They need fluid resuscitation. And we can use lactate and normal saline at 20 ml per kilogram as a fluid resuscitation. And then you need to slowly correct the electrolyte abnormalities. We usually can use about 10 ml per kilogram per day. And the solution we use is 0.5% normal saline, not a full normal saline. It should be 0.5 normal saline with 20 to 30 milliequivalents of KCl and dextrose solution. So that solution, most hospitals has them, but if you do not have, you can actually create the solution. And then once you have corrected the electrolyte anomalies, then we can transfer the patient for surgery. It is interesting how pyloric stenosis is not a surgical emergency. It's a medical emergency. You are unable to take that patient to theater without electrolytes and rehydration being corrected. They are actually targets that we use in terms of preoperative assessment for these patients. So it's a medical emergency, which needs medical electrolytes needs to be managed before we can even consider the patient for surgery. What we need, we will then do, we'll do pyloromyotomy, what you call the Ramstead pyloromyotomy, which can be done as an open small incision on your right upper quadrant, or in my practice we do laparoscopic pyloromyotomy. And I would like to emphasize again, only when this child is fully rehydrated and electrolytes are within acceptable range and alkalosis has been corrected, then only these patients can qualify for surgery, because they will not be able to be anesthetized. The second topic that I will talk about is a patient then that presents with malrotation and with or without mid-qut volvulus. We need to understand that 3% of the population has malrotation, and we are actually fine. We are walking around the street. So you will find some patients who have malrotation but not have symptoms. But 50% of the patients with malrotation then will present with the symptoms at least within the first month of life, and almost 75% in the first year of life. We need to understand that malrotation is a disease of failure of bowel fixation and rotation and fixation that allows your appendix to be on your right iliac fossa, your ligament of trite to be on your left upper quadrant, and your bowel to be, as we know. So patients with malrotations, as you see on one of the slides, that most of their small bowel is on the right, all the large bowel is usually on the left, with the appendix on the right upper quadrant, and they don't have a normal duodenal C-loop and fixation of their ligaments of trite, which result in them getting a very narrow mesentery. So that then, with duodenal obstruction from the left bands that are crossing on the duodenum, results in this being an emergency, especially when they develop mid-qut volvulus, because the short mesentery makes their bowel turn on itself and then stops the blood supply. This is the only true pediatric surgery emergency, because the time it takes for that bowel to become completely ischemic depends on the twist. And once it is ischemic, it means the patient loses his entire small bowel, and that is incompatible to life. So you need to know what is wrong with the patient, because these patients are usually healthy children. Most of them, just after 1 month, they present with bilious vomiting. Bilious vomiting in a previously healthy child who was discharged home, it's a serious matter of concern for us as doctors, because we need to investigate. And then the investigation, abdominal X-ray is not really confirming, but you should be able to see distension sometimes of the stomach. That is only in patients that has complete obstruction and no distal gas. But the only way to confirm this is upper GI contrast study. This upper GI contrast study is not done tomorrow morning or when the radiologist is up or when they're finished doing anything else. It's the only investigation. When we call a radiologist, it has to be done as the time is ticking. And it is the most important investigation you can do so that you can make the diagnosis. Once we have made the diagnosis of malrotation, especially if we suspect volvulus, then the patient needs to go for urgent surgery for last procedure. Radiological things that we look at the absence of C-loop. We are looking at the trias not being at the level of the pylorus. We look at contrast not passing onto the left side of the abdomen, because it's only on the left side. Because the small bowel is on the right side. So these patients then would go for urgent surgery, which we call LATS procedure. When we do LATS procedure, basically we remove the LATS bands that are causing duodenal obstruction. They are all owing over the duodenum, causing external obstruction. That is what we remove. Once we have done that, then we do widening of the mesentery, because we know that the narrower the mesentery, the more likely that it will volvulus. Then after that, we move the small bowel, we put it towards the right of the patient, and then the large bowel towards the left side of the abdomen. And there is controversy as to, do you do appendectomy in that setting or not? But in patients who we know that the chances of them being missed to having appendicitis, which will be on the incorrect side, we still believe, some of us, that we do appendectomy. And both this operation, the last procedure in itself, can be done either open or laparoscopically. Most people who do open, they are worried about whether people who do laparoscopy widen the mesentery adequately, but it should not be a problem. The third topic that I will talk about is intussusception. As we know that intussusception actually is a telescoping of the proximal bowel into the distal bowel. So imagine your small bowel telescoping into itself and into the large bowel. It's usually a disease of infants and toddlers. We do not really see much of it beyond that time, because its peak incidence is usually between 5 to 9 months. This is like 80% of the patients you will see with intussusception within that age group. It's very rare in patients who are below 2 months old. And any patient who presents with intussusception to my practice who is more than 2, I look out for a pathological lead point, because there should be a reason why they developed intussusception. What is actually the cause of this 80% of patients we see with intussusception is idiopathic. 90% of it is idiopathic. It's because of hypertrophy of hyperplasia of a lymphoid tissue, which we call Peyer's patches. And then that acts as a lead point to push the proximal bowel into the distal bowel. And we have actually noticed through research that this actually is preceded by a child having a viral infection. So ask the question, has this child had upper airway a viral infection or gastro previously? Because that infection is actually what causes the hypertrophy of the lymphoid tissue. There has been some viruses implicated, like adenovirus, rotavirus, and HSV6. So now again, we have a patient in front of you. Always ask, what do I think is wrong with my patient? Because that's the most important thing, because then you will look at the clinical presentation and then decide what to do with the patient. These patients with intussusception present with colic intermittent abdominal pain. It's a child who cries unconsolably for 30 minutes, 40 minutes. Suddenly they stop crying without you giving him anything. And then they cry again, because usually the intussusception goes in and out until it is in and it cannot retrieve itself anymore. So that is one of the things you need to look for: a colic, intermittent abdominal pain. They present with bilious vomiting because they've got a positional obstruction. And then they get a fresh bloody stool, which we call as current bloody stool. And it's important to realize this is not malignant stool, because most people send patients with malignant stool. This is fresh blood usually. So be aware that it looks very red blood. The other issue then we look at is post-viral infections, as we discussed, but the patients are very, very well nourished. Because you will see most people who have treated patients with intussusception, they are very chubby children. To put a drip on that child is very difficult. So I always say, a child who presents with bowel obstruction and you can't put a drip on, you must suspect intussusception until proven otherwise. How do we then investigate these children? We can do an abdominal X-ray, then preceded by abdominal ultrasound to confirm the diagnosis. X-ray just shows basically some signs of intestinal obstruction. But abdominal ultrasound is confirmatory, because that is where you see what you call a target sign or a donor sign or pseudokidney sign. And it's the only way really to confirm intussusception, of course, based with other clinical correlations. One of the very important things I want to mention is a patient or a baby who's got what is thought to be rectal prolapse. Those patients, you must be very careful that you're not looking at intussusception. The difference between rectal prolapse and intussusception is that with rectal prolapse, if you put nasogastric tube on the side between the anal wall and the prolapsing rectum, it goes in and stops within very short, like maybe 2 to 5 centimeters. But with intussusception, that nasogastric tube keeps on just going in. So these patients needs urgent reduction, but they need to be resuscitated before that. So our reduction can either be radiological or surgical. By radiological, I mean pneumatic reduction or under fluoroscopy or hydrostatic ultrasound guided reduction. A surgical reduction can either be laparoscopy or open, depending on how sick the child is, and actually in the period. I found that patients who present on day 3 and more, I struggle a little bit to reduce, especially the ileocecal valve laparoscopically. But the early presenters is quite okay to then opt for laparoscopic reduction. And then as we move down the GIT, as we see now, we come to the colon. At the colon, I thought we could discuss a little bit of Hirschspung disease, which is the commonest cause of functional intestinal obstruction in childhood. And I want you to highlight the fact that it's functional. It's not a mechanical obstruction, it's a functional obstruction. And that is because of failure of migration of the neural crest, or none, which result in there be no ganglion cells at your plexus. Most of it, 70 to 80%, is rectosigmoid disease. That is why a rectal biopsy can be able to show you. We do get a long segment Hirschspung disease and total bowel ganglionosis, which is a terrible disease, of course, to have, because it's not really compatible to surgery. The most important thing I want you to take home with Hirschspung disease is Hirschspung's associated enterocolitis, which happens in about 16% of our patients. These are patients that is signs and symptoms of Hirschspung disease, but they are very sick. They are acidotic, they are septic, and you should be very, very careful. Look at the white cell count of these patients and suspect, be very high suspicion of enterocolitis and treat it promptly. Again, you will have a patient in front of you. The most important thing is your history and your clinical investigation. So these patients present, when you ask the mother, they say they had delayed passage of meconium. That delay is any child who did not pass meconium between first 24 to 48 hours of life. Those are the patients that you need to really, really think about Hirschspung disease. They present with bilious vomiting because there's an obstruction, but it's more of a delayed a symptom, but they've got abdominal distension. The kind of abdominal distension for Hirschspung disease you cannot miss. I always say it's like a football. You will see this has been a chronic abdominal distension. There's no way that this abdominal distension started last week. Most of these children have been having this football that they carry around for very long. So the way you diagnose, you can do abdominal ultrasound, where you will say distended, massively distended loops of bowel, which we call head trapping. Once you see that, you can, when you examine them, you do a PR, they get explosive diarrhea, they decompress. It's like you have cured the disease because of the stenosis or the collapse of the distal rectum. Then we should do a contrast enema for them to look at the disease pattern. And contrast enemas, you see the distended part of the large bowel. That is actually the normal bowel. But the collapsed part from the rectum, that is the diseased bowel. As you can see there will be a funneling or a cutoff, a funneling where the normal bowel or distal collapsed bowel come together, or what they call transitional zone. So you will be able to see where the disease more or less ends. But the only way to confirm Hirschspung disease is to do a suction rectal biopsy or full thickness rectal biopsy, which is sent to the pathologist. they will come and say there's aganglionosis, then these patients can be treated promptly. But for a doctor who's at the peripheral hospital, at that point, we expect the patient to be NPO, to receive IVI fluid bolus, to be started with antibiotics, especially if we are thinking about Hirschspung-associated enterocolitis. You can do anal dilatation to decompress, as I've explained, and do saline rectal washouts with 25 mL per kilogram BD. And this is what we do for most of these patients before surgery. So doing anal rectal decompression and rectal washouts until we work them up and we do a stoma. As we say, the stoma is a semi-agent for all of them, unless the patients have enterocolitis and other things. And then the operation we do for that is transanal pull-through, which means we remove all the diseased bowel, which is from the rectum, at least 2 to 3 centimeters above the anorectal verge, until the transition zone. We take that, we throw it in the bin, and we take the normal bowel, which has ganglion cells, and anastomose it in the anal canal. It's important to also think about the differential diagnosis, because we get lots of calls about patients with Hirschspung disease. There's what we call a neonatal small left colon syndrome that you must be aware of. We get lots of patients with meconium plaque syndrome and meconium ileus. And the good thing about this three diagnoses, you can see them on contrast enema. And meconium plaque syndrome is actually, contrast enema is also therapeutic for this patient. Which usually patients with meconium ileus, you will see some calcifications as well on abdominal X-ray. And I want to emphasize, look out for other causes of chronic constipation in these children and treat them. And then I will quickly go through anorectal malformation. Basically, is malformations of the rectum and anus that are not continuous. So we can get different ones in both boys and girls. The most common one, it means there is no anus. There's no, the anus is not located where the muscle complex is. So there is a hole, but it's at the wrong place. So that's a perineal anus. It is still an anorectal malformation. We can get others like a bucket handle, as you can see, lifted there. And then for males, we will of course get a fistula that goes to the urethra or the bladder, which is a rectovesical or recto-urethral fistulas. And in males, it can be a rectovestibular, which is almost in the vagina, and common cloaca. It's important to be aware that anorectal malformation is associated with other abnormalities in about 60% of these patients. So you have to investigate everyone with anorectal malformation. For vectral, which the V stands for the vertebral abnormalities, so it's important to take a babygram X-ray from your base hospital. It does not help to bring a child with a chest X-ray. A babygram is an X-ray from the head, including the limbs and the whole body of the patient, because we are able to detect other abnormalities. Look for the anus or anorectal malformation. Patients will have cardiac abnormalities. These patients will have tracheoesophageal fistula in some of them. That is why we insist that you put nasogastric tube. Some of them will have renal abnormalities, which we will detect when we do KUB ultrasound. And some might have limb abnormalities like Epstein radius. So this patient needs to be kept near the mouth, because clearly you cannot feed a child who cannot poop. And then put in a nasogastric tube and resuscitate them with fluids. And then the patient can be transferred for a stoma. These stomas are only agent usually if they are boys who've got recto-urethral fistula, because there's no way of them decompressing. But most females with vestibular fistula can decompress and can be treated. The stoma is not an agent matter. Some patients that, especially as I mentioned, recto vestibular fistula or perineal fistulas, we can do primary PSAP on them. And some doctors will decide whether they want to cover a stoma or not, or some say no stoma, they put a child on TPN. But most of them, they still get a stoma or one way or another, unless they are early and well child and perineal or vestibular fistula. The other second topic I would like to talk about is inguinal hernia. It's the most common cause of intestinal obstruction in infants. And like I said, this is a mechanical obstruction, because we understand that because of failure of the processus vaginalis to close, there is then a channel that goes to your inguinal ring. And all of them have direct inguinal hernia because of that knowledge that we have. And I want to emphasize that most hernias are reducible. The call we get the most as pediatric surgery is there's non-reducible hernia. And I have maybe dealt with 3 not completely non-reducible hernia if they are presenting, because of this patent processus vaginalis is patent for so long that suddenly there is complete obstruction. We should be thinking otherwise. But please, with that said, look for signs of incarceration and or strangulation, because then these patients, we need to help them more quicker. So the incidence of incarceration, we need to be aware in the total number of all these patients that get inguinal hernia is only 17% of those that are in the right and 7% in the left. So it's a very small number of patients that do get that. But this incidence goes very high, or it's almost times 2 in patients who are preterm babies. It can go up to 60% of those patients. We need to be aware as well that two-thirds of them happened within the first year of life, with 17% being girls and 12% being boys. So we need to look for complications. It is not about the hernia, it's about other complications, which are intestinal obstruction, bowel ischemia, necrosis, and strictures in the future. We need to look for those. It can also cause things like testicular or ovarian atrophy and infarction, which we need to be aware of. So do I need to reduce or refer? This is the critical question. As I said, 90 to 95% of patients, the obstruction is in the internal ring and they're reducible. So it's impossible that every patient that is incarcerated hernia becomes a non-reducible hernia. Research has shown 95%, 90 to 95% of them actually just reducible. But how do we reduce is important. So manage the patient. This is a sick child. NPO, nasogastric tube, decompress the standard, make them comfortable, give them IV access, something for pain. Now you've got a calm patient who's not crying, who's not pushing. You can sedate the child, conscious sedation after you have resuscitated, and I use ketamine because it's a very simple and easy drug which doesn't cause much of respiratory suppression. We usually give 0.5 to a maximum of 2 milligrams per kilogram. IV will reduce. And as I say, I mean, both private and public and state practice, I think I've only had 2 or 3 maximum patients that I could not reduce after I had sedated them. And then look for other signs. I mean, there's very clear when a patient has bowel ischemia or strangulation. Those are the patients that you need to think twice before, because for you to refer a patient with an incarcerated hernia, which has bowel that is a blood supply that is dying by day, all the way from one hospital to a hospital that's going to take 9 to 10 hours, you have actually done a disservice to that patient. Whereas you can sedate the child, reduce the bowel, and most likely still send the patient for elective date, but then you know that you have saved your patient. Contraindications is strangulation, which is only 10% of the patients. And out of those who are strangulated, we only find 1 to 2% of them having intestinal injury. So it is not a catastrophe as it is maybe in adults. And look out for peritonitis and septic shock. Those patients most likely have strangulation. Lastly, we talk about abdominal wall defects, gastroschisis and exomphalos. Exomphalos, as we know, it's the lateral fold defect of the umbilicus, which result in failure of the mid-qut to return in the abdomen. So 45% of patients with omphalocele have associated other abnormalities, especially cardiac. About 20% have chromosomal abnormalities such as Down syndrome, trisomy 21, and Beckford-Wiedemann syndrome, which we see as a patient with omphalocele, macroglosia. They usually have hypertrophy, organomegaly, and have neonatal hypoglycemia. Neonatal hypoglycemia is what actually kills this patient. So please do blood glucose level and correct it. It does not help to transfer any child with omphalocele if you have not corrected the glucose, because they will not get where they are going. The second thing is take care of that membrane, because if that membrane ruptures, it's an absolute disaster for these children. It's not like gastroschisis, which I will discuss later, where we can put silo bags and do other things. It's an absolute disaster, very high mortality. The other thing that we need to know is that you can have other organs in there, like the liver, the spleen, and gonads. But the management of omphalocele is conservative. Very few of these patients go to theater. Maybe those with the omphalocele minor, with a defect is less than 5 centimeter. But most of them are conservative. We put genital violet on them, we leave them alone, the membrane gets hard, they go home. They have a ventral hernia, which we will correct later. Some centers still use mercurochrome, but genital violet is actually what we use. Patients with gastroschisis have a defect that is lateral to the umbilicus, and I want you to be aware. It is lateral and is towards the patient right side. That means the cord of the umbilicus is on the left of the gastroschisis. They're usually seen in younger mothers and premature delivery more frequently. Etiologies is not really known, but it's associated with drug abuse, especially vasoconstrictive drugs, aspirin, cigarettes. We are still trying to figure out what are the causes, especially in a place like Limpopo and Mpumalanga, where we have so much gastroschisis that is unexplainable by what we think is causing gastroschisis. They do not have much associated abnormalities, so they're usually healthy children. Some about 10 to 15% might have intestinal atresia. The management of these patients is also not surgery, it's resuscitation, making sure they get transported well. So usually what we do in our center currently, we treat all of them conservatively with a silo reduction. And none of them goes to theater for anything. With silo reduction, we reduce them. Once the bowel is in, we close the skin with a dressing, and they go home. Some people still choose surgical closure, either by primary closure, or they use a stage reduction with formal sheath and skin closure later. It is not what I do in my practice, and I have not had any problems with these patients. My problem with these patients is failure to resuscitate from base, mismanagement of their bowel, and sepsis. So we need to know that the defect is towards the right, and protrusion of the abdominal content, and there's no covering and contains gonads, and it's a smaller defect. I have included the protocol, which I will not go through, that we use, and the summary. We must be aware there's also unusual abdominal wall defect that we see, like pentalogy of Cantrell, which comes to us and with associated with those. Quickly, 2 minutes on patient transfer. Factors to consider: is transport necessary for the patient? Is the timing of the transfer appropriate? And what is the management ABC resuscitation of this patient? So we use 2 sites to decide on what to transfer, which you can read.
Hi, Doc. Am I on the right slide?
I am not sure if I went. Yeah, you are 2 slides. You are 2 slides behind me. I was moving quick.
You are on the.
And I am now transporting patients so that I can conclude.
Okay. Yes.
Yeah.
Thanks.
As I said, we can use two sides to decide that does the patient have an AT tube, NG tube? Is the patient warm? Are you giving your patient oxygen? Is the patient stabilized? You have dealt with sepsis. You have dealt with investigation. You have documented. And who's going to escort the patient? And please sort out the consent form if you can, as much as you can. So in summary and in closure, babies are not small adults. They've got different pathology, presentation, and management. Watch out for warning signs. Blood, bile, are they growing? Do not underestimate fluid requirements in pediatric patients, but please do not overdo it. Fluid resuscitation of the baby with interception and book an ultrasound. Reduce the inguinal hernia in casualty, under sedation. Place a silo bag on gastroschisis and rapid transfer in sudden onset of bilious vomiting, while the anesthetist puts the malrotation child to sleep. Thank you.
Thank you very much, Dr. Mklu. There was a lot, a lot of information. Yeah, no, it was really a marathon. It was a lot. I don't know why there's an echo. Is it only me who's having an echo? Okay. Hello. Okay. I don't know if anybody can hear me. There
I can hear you.
Okay, there is a couple of questions on the Q&A. There is Lydia wants to know if we can have these sessions every week. I don't know if we can do it every week, Lydia, but we're trying to do it as often as we can. And then there is a question about, I think from Dr. Mudiba, he wants to know if gastroschisis, maybe we should just go through the questions and then maybe you can try and answer them at the same time. Dr. Mudiba's question is about prenatal diagnosis of gastroschisis with ultrasound. He wants to know if it can be diagnosed. And then there is an anonymous attendee who's asking about Hirschspung's disease, Hirschspung's disease in children who are over the age of 5. I think that's just delayed presentation of Hirschspung's disease. And then as well as the rationale behind the fluid bolus if the patient is not in shock. And then I think there's also a couple of attendees who are asking for the slides. So I think everybody, don't worry, we will share the slides with you at the end of the session or in the next coming few days.
Yeah. My quick answer, if you can hear me. Of
yes,
course,
we can.
most of neonatal diseases or pathology we see, it's actually antenatal diagnosis. Almost all of them. But we know that we do not have very good antenatal diagnostic skills, especially in our state sector, which needs to improve so that we know beforehand. So it is possible to diagnose gastroschisis antenatally. Hirschspung's disease is a congenital abnormalities. That means you are born with it. We have just missed it all the time. And then I'm not sure if you're talking about fluid bolus. If you're talking about fluid bolus on a patient who has gastroschisis, my answer is yes, yes, and yes. And always think about fluids, because they are so behind. They are losing fluid by day. And then, the flights will come through.
Yes, I think somebody is asking a very important question here. You talked about inguinal hernias and that it's if the hernia is reducible, rather you sedate the patient and reduce it. But they're asking, I think this is a very relevant question. How do you reduce the hernia? Because it's not literally just pushing it back. You have to understand a bit of the anatomy for you to know which direction to push it.
Thank you very much. I thought I should have actually indicated on one of my slides. So it's very important to have a calm, non-crying child. You put the child on the bed or on the mother. and then you know the direction of the inguinal canal. You where the hernia is. You hold it as if you are holding a structure in between your four fingers and your thumb. That is where you hold your canal. Then you make a sprouting compression from the bottom where the actual scrotum is. It's continuous pressure. You do not let go. By compressing on the inguinal canal, you decrease the edema and you guide this hernia and you just continuously press. I usually press for 30 to 60 seconds without leaving the pressure. And I'll only leave the pressure if I want to give the child a rest. But usually they are calm and sedated.
All right. Yeah, and then I think maybe another basic question about what can you use to cover the gastroschisis. I think we are all tempted to want to put sterile linen on. Yeah, which is not the correct thing to do. Somebody is asking about that as well.
Yeah, so if I could get a silo bag in every hospital in province, then we have cured gastroschisis. We will have such wonderful outcomes. And I'm trying to motivate for that. But you can use a normal saline bag. The idea is to just cover the bowel completely and make sure that it does not lose fluids. And put the patient towards the right so that you don't cause bowel ischemia. Once you have done that, by the time they get here, we will get a silo on them and put a silo.
Yeah, I think maybe if I could add that maybe they must just remember that if it's not necessarily a saline bag, it's something that's non-adherent, because someone will say, what if I don't have a saline bag?
Yeah.
Something that's non-adherent and that prevents moisture loss, it should work. Because sometimes you don't know where babies get delivered at the clinic where there's literally nothing. I feel like if you don't have anything, you can literally go to the kitchen and get clean wrap and come and cover the bowel, because that's non-adhesive dressing. So you can't say you don't have that. Yeah. So what did I want? I think maybe
I saw a question by Sophia Black at the 1851. She said, "Thank you. This is informative. But what can I do as a nurse?" She said she lost one child because of a burst appendix. I'm reading directly as written. And then she says one nearly died that had a pyloric stenosis. So she's trying to figure out, as they present at primary care, what are the priorities there? Yeah.
Okay. Just to answer, when our unit here in Mpumalanga has made a provision to make sure that all the transfers comes through VULA, and is working very well, because any health professional can work on VULA. And if you put any question on VULA, I will be able to receive your question. I receive referrals from clinics, from nurses, and then I'm able to help them directly and to give them feedback once I discharge the patient. So it is important to use VULA, because if sometimes you call me, I'm either operating, and as one person who's receiving more than 100 calls a day, it means I must just sit and be on the phone the whole time.
Yeah, and I think maybe just to say something about what you were following up on, Dr. Mawela. I think it's important to remember that common things occur commonly. I think having appendicitis, I think we should all know that when children have gastroenteritis, most of the time it's a self-limiting thing. And most of the time, gastroenteritis is associated with cramping and some colicky pain. But patients who just have complaints of nausea and vomiting, and then now they have diarrhea, and then you must suspect that there is pus in the pelvis. That's most likely a ruptured appendicitis, and we should have a high index of suspicion. And another thing is also, maybe Dr. Mplong can elaborate further, appendicitis in infants, because I think we only think of appendicitis now when the children are now like 10, 15, 7 years old. But when they are 3 years old, we never suspect it, but it's something that's also possible in those kids.
Yeah, thank you, Machida, again. Yeah, it is very important to have high index of suspicion and always ask. It's very important to ask than to make your own assumptions, especially when your responsibility, if you remember on my first slide, is you must think, what is wrong with my patient? If you think of a diagnosis, what are the clinical pictures? Then how can I get the patient to be treated? Rather than what we find, most doctors just want to transfer the patient.
Yes,
Like they say, yes, a patient, and transferring the patient is not a priority. The priority is to know what is wrong with the patient, resuscitate the patient, package the patient properly, and make sure the patient gets alive where they're going. It does not make sense to put a gastroenterologist on a helicopter. I do not know where they want to fly to. Package the patient properly. When the bowel is covered, you have given fluids, the patient can come. It's not like something's going to happen to the child now. Same as pyloric stenosis. It's not a surgical emergency. It's a medical emergency. Correct the electrolytes, transport the patient when the patient is stable. So we need to focus on how do we transfer, when do we transfer, where do we transfer?
With regards to sedation, you've mentioned ketamine. There's two small questions. One is asking, can it be used for children, for infants less than 1 year? And one is asking as well, Fundo, saying a quick comment on appropriate sedation in an outpatient setting. Probably they're meaning outside of the hospital, I guess, or something. I'm not sure.
Thank you very much. This is such an important question because I often get lied to by every consult I get. I said, okay, did you sedate the child with ketamine? And everybody says yes, but they know they did not. And I understand why. People are so scared of giving a sedation. And I understand it has to do with experience and being comfortable with this. For most patients, it is true. For patients who are less than 1, you must be more careful. That is why you need to look at your doses and look at your patient. We know that I'm not talking about patients who's got peritonitis and strangulation. We're talking about patients who are crying because their bowel is stuck in. Give 0.5 mils per kilogram and see what happens to the patient. Connect the patient to have a drip. Connect the patient to oxygen. Connect the patient to a CES monitor. That's all you need. You don't need to go to theater. You don't go to anywhere. Measure the saturation. Have a drip. Ketamine is a very low, short half-life. And then you will see your patient is not relaxing. You increase, you add the other 0.5. Now you're at 1 milligram. And most of the patients, I have not had any problems in my practice with the use of ketamine, because we also use it for patients with bends on a daily basis in the ward.
Yes, true. And also with the bends, you find a way. If you're worried about giving IV ketamine, you can give oral ketamine, and it also works and it's quite safe. The only thing is that maybe remember that you don't want the child to start vomiting because they can have lots of secretions and all. It's better if they've been nil POs for a while. You can let them eat and then give them ketamine, after 30 minutes. I think that's one thing to remember, but it's quite safe. I agree.
I think I've ran through most of the questions. Is there any last question in the Q&A?
Yes, there's Lino Sono is asking about congenital diaphragmatic hernias, as to whether they can be operated here in Rob Ferreira, or do they need to transfer these patients to Steve Biko? I don't know, how often do you see the patient with congenital diaphragmatic hernia?
I do not know of any pathology that cannot be operated at Rob Ferreira unless we want to manufacture one. It's a tertiary hospital in the province, and we are able, both general surgery and pediatric surgery and other surgeons, to operate on any patient. And we do see congenital diaphragmatic hernia, and again, it's not an emergency. It's a medical emergency because they've got pulmonary hypertension. But if you see a patient, you can always contact us as pediatric surgeons to be aware. We do lots of thoracic work. So most thoracic work, except the heart, that is going to cardiothoracic surgery, but the other parts in the thoracic or in the chest, we do deal with them, especially if they are congenitally acquired.
Someone is asking about how soon should they refer neonates with inguinal hernias? Or maybe while at that, maybe let me just also ask if you can elaborate on umbilical hernias, because then we've seen referral of 2-year-old with umbilical hernias. So maybe that, how soon should this patient be referred?
So with all hernias, as I said, we must decide, is it a simple hernia or is it complicated hernia? Complicated means incarcerated strangulation. If it's incarcerated, we reduce it. If it's strangulated, we've got bowel preparation and other issues. Patients who just has a hernia, which is an umbilical hernia, do not have to be repaired until they go to school. That is age of 5 and 6. Before that, most of them, the percentage is 82 to 85% will close on themselves. Please leave them alone. But if they have got complications, then we can look at those patients promptly. But most of them, a child who's born with umbilical hernia, they have an umbilical hernia, it will close.
Does it apply for inguinal hernias as well?
No, it does not apply to inguinal hernias. The inguinal hernias, you must refer. The question with inguinal hernia is this simple, reducible? Yes, they get a date of the clinic. Is it incarcerated? You give them the reduction at casualty where you are and call us about the patient. If you have worried about bowel strangulation, dead bowel, you call us, we will advise you what to do.
All right.
But all of them will receive a repair. And at Ro Ferreira Hospital, they all get laparoscopic inguinal hernia repair.
Prudence is asking about normal saline because you specifically said 0.5%, and she only has 0.45 and 0.9. I'm not sure how relevant, but because she's posting it.
Yeah. Sorry, that was a typo. It was a typo. Okay. It's 0.45. Sorry, it's a typo.
Okay, yeah.
Before you share the slides.
Yeah, because she's posting this for the 3rd time, so I thought, oh, she's gonna call me after this. I said, but you didn't answer my question.
It's 0.45. So it's half normal saline.
Yeah, sure.
All right. I don't know. Is there any more questions, or can we close the session?
No, that I think we can start to close, Dr. Tehana.
Okay. All right. No. Yeah, I think it was a great session. There was a lot of things that I think most of us are enlightened on. And yeah, thank you very much, Dr. Mklu, for your time to come and share all of this with us. And hopefully this will make a difference in the management of children in the entire province and everywhere else. Yeah, the correct resuscitation, diagnosis, and correct referrals will be done, as this is what's necessary for us to improve patient care, which is really the purpose of this platform, to improve patient care through improving our skills and knowledge as healthcare professionals. So thank you very much. Thank you everyone for attending, for staying with us. We went past the 1 hour allocated time, but thank you. And also thank you for your patience at the beginning. We had a little bit of a glitch and everybody was patient with us. Yeah, thank you very much. I don't know, Dr. Mhlung, if you have any closing remarks or if we can go on and close the session.
You know, I was just about to say again, thank you for the opportunity and the people who have listened in, and I hope all of us will learn something. I will send you the slides with correct information, especially on normal saline, and then thank you. And I will attach on the slides our contact details and our VULA details. We wish that every doctor in Mpumalanga will be on VULA so that they can communicate with us directly. Thank you very much.